Director General of the World Health Organization, and we're delighted that we have here today Dr. Philippe Douste-Blazy to present his case. Philippe visited here in April, and during the quiet, soft phase of his campaign, early days, and we discussed the possibility of having a public session at this time, and he said he would return, and he's back. So thank you so much for agreeing to do this. I think it's terribly important that this kind of public session be happening. I think that it gets the issues out to a public that's really interested. You can see we have a great group assembled here today. We have a great group online as well, live, and we'll post this, and many other people will be able to take advantage of it. Few words about our guest of honor today. Philippe is the Undersecretary General and Special Advisor to the Secretary General on Innovative Financing for Development. He's the founder of UNITAID, which was mid-2006, which was the advent of a €1 micro levy on air tickets, which since then has generated over $2.5 billion in innovative financing from, I think, 12 partner countries. Is that right? 12 partner countries. He still serves as chair of the UNITAID board, the executive board. He followed up that creation with the establishment of the Medicines Patent Pool in 2009. He's a cardiologist. He served twice in the French government as Minister of Health. Served also as Minister of Culture and Communications and Minister of Foreign Affairs. And while he was Minister of Foreign Affairs, he welcomed us, CSIS, for a CSIS Government of France joint forum in Paris in May of 2007 on building U.S.-European cooperation. That was the period when Michel Kazakhin was President Chirac's envoy on pandemic diseases. And that was very successful, and we're very grateful to you for hosting us at that time. He brings an exceptional mix of career achievements. A medical practitioner, doctor, a public health and medical policy expert and innovator, an elected official, and someone with experience in high diplomacy and foreign policy, as well as now finance. There are 5 other official candidates now in the mix, along with Philippe. There's Tedros Adhanom Ghebreyesus, the current Minister of Foreign Affairs of Ethiopia, former Minister of Health. There's Dr. Sanya Nishtar, the Pakistan Minister of Education and Training, former Minister. Miklos Shoshka, the Hungarian former Minister of Health. Dr. David Nabarro from the UK, who's the Special Advisor to the UN Secretary General on Sustainable Development. And Dr. Flavia Bustreo, the Italian Assistant Secretary General at WHO for Family, Women's, and Children's Health. So we have an array of 6. I think when Margaret Chan was first elected 10 years ago, there were 13. So, and then she was unopposed second term. So we have a more manageable process in some respects, and an interesting one. And I'm hoping that this occasion here inspires other candidates to come forward. We talked about this a few minutes ago. I think it would be useful if we can do that. Special thanks to my colleague Katie Peck for pulling this entire affair together. Thank you, Katie, and special thanks to Céline Yegi from the French Embassy for all of her good work. The election process that is underway right now is a new process. In the past, the 34 members of the WHO Executive Board would nominate one candidate and forward that nomination to the World Health Assembly in May to be on an up or down secret vote. Now the Executive Committee, the Executive Board, will consider 5 candidates in its January meeting, which will be just a few days after our new president is inaugurated, and we'll make a decision to forward 3 candidates to the World Health Assembly in May. Am I getting this all right, Larry? And then it will be decided, I believe, by a secret ballot at that time. So there will be a secret ballot in the WHA Executive Board, WHO Executive Board, as well as all member states in voting in May at the World Health Assembly. Whoever wins then takes up the duties July 1 as Margaret Chan retires and the new Director General takes up the post. In the past, there's been criticisms of the process as involving a lot of backroom horse trading with little transparency. There's always been a discussion around geographic blocks and whose turn is it. There's been a perception that this is Africa's turn, and that contributed a bit to the efforts by Minister Tedros to win support from the AU, official support from the AU for his candidacy back in January. These remain controversial issues, and it remains to be seen whether the process this time around is more transparent and accountable than what preceded it. We'll see. I also want to point to a few exceptional aspects to this moment that we're in right now as this competition and eventually the election of the next Secretary General, Director General unfolds. First is that we're in a period of a wholesale turnover of leadership of UN and related international bodies. We're going to have a new Secretary General, a new head of UNICEF, the Global Fund. Jim Kim was just put forward for his second term in the World Bank. There's lots of wheels turning in this crowded geography of international organizations. The second, I think, very important thing to keep in mind is that this is the first election post-Ebola, and it comes against the backdrop of no fewer than 6 major studies of what happened during the Ebola and what that meant. Each of those studies considering what that meant in terms of WHO's performance. And that's pushed forward, as we'll hear from Philippe, that's pushed forward an intense debate around what types of reforms need to happen within WHO, in what time frame. I served on one of those, and Larry Gostin and I served together on the Harvard London School of Hygiene and Tropical Medicine panel on Ebola, and there was a lot of consideration there about the type of leader that was desired in this next phase. A lot of emphasis on finding a person with gravitas, a statesperson with deep diplomatic experience and mediation experience and skill, and an ability to speak truth to power, along with carrying out major internal reforms and to bring the relationships with the NGO sector and the private sector into this century, and to modernize human resource practices, bring about greater transparency. We'll hear more about all of that. I think that it is going to be a central concern as we make judgments around who is best fit for this particular moment. So please join me in welcoming Dr. Douste-Blazy. He'll be presenting his slides and argument, his case, and then we'll have a conversation after that. Thank you.
Thank you, Stephen, dear Larry, ladies and gentlemen. It is a big honor for me to be there. Thank you very much for inviting me today. I am going to share with you an agenda to renew WHO leadership. It is a big challenge. So what is my vision for WHO? As Stephen said a few seconds ago, I think we have to probably implement a culture of improvement and a culture of evaluation and assessment in the WHO. To fulfill its role as a leading institution in global health, the WHO must be managed efficiently and must consistently demonstrate results and impact. It is probably the key for me, results and impact. Because if we don't do this reform, we are going to see that the confidence will diminish. The big donors are going to give less to a critical level of resources. And we are going to see new parallel structures who are going to emerge. What happened during the last 2 decades? Each time we had a health issue, the international community created a new fund against HIV/AIDS, tuberculosis, malaria, Stop TB, Rollback Malaria, UNITAID, Gavi, each time outside the WHO. So my question is, do we need or not a WHO? Do we need or not a strong WHO? Yes, we need a stronger WHO, but if we need a stronger WHO, we have to work for the confidence of all state members. So we have to strengthen the relationships between member states and the organization, and we have also to serve directly the needs of the member states, delivering on SDG 3, achieving universal health coverage, and strengthening global health security. So, my first decisions would be implementation of a strong audit function addressing underlying risks. Implementation of an effective human resources system, by the way, with progress towards gender parity, from the headquarters to the regional directions to the country offices. And define clear lines of accountability between the 3 levels of the organization. Priority 2, responsiveness. And of course, particularly for an effective response to emerging, re-emerging, and infectious disease outbreaks. The world continues to look, fortunately, to WHO for leadership during health crisis. But, as you said, Stefan, a few minutes ago, Ebola. We can learn a lot from the Ebola crisis. Ebola exposed the compelling need for a strong, responsive, and resilient health systems to identify infectious disease outbreaks, and a global and strong leadership coordination. So my first decisions for responsiveness is implementation of the health emergencies program, clear lines of authority, because for the emergencies program it's absolutely crucial who is the commander-in-chief. Not obligatory the DG, but we have to know. And for me, and we discussed with Larry yesterday, we think that we need an independent assessment of the severity of disease outbreaks. We saw with H1N1, we saw with Ebola, it's very difficult. So after that, the DG and the team has to decide. But if we can have before an independent assessment of the severity of diseases outbreak, I think it could be better. And also a summit to secure, very quickly, to secure reliable long-term funding for this health emergencies program between member states, major donors, World Bank, IMF, etc. My first decision also, fifth, redefinition of country support, with strong teams in regions most at risk, and also decentralization of budget. But if we want to have that, we have to implement a predictive risk mapping. And we don't have this predictive risk mapping today. And also asking all WHO representatives to undertake humanitarian emergency leadership training. During the Ebola crisis, you know, MSF, Médecins Sans Frontières, UNICEF had humanitarian emergency leadership training. And finally, engage partners. Of course, the others UN agencies and also NGOs. I think that we have to structure our relationships between WHO and NGOs to share information. Priority 3, results and impacts underground. So WHO cannot be everything because the budget cannot do that. So WHO's priorities must be determined with a focus on impact. And we could deprioritize also most aggressively at the WHO headquarters, but we have to clearly communicate for that. My first decisions for results. First, link budget to results. With implementation of a strong focus on value for money and efficiency, zero tolerance approach to misuse of funds. And second, implementation of a monitoring and training function, independent and internationally recognized. By the way, I think that we need only one team between the team of health systems and the team of universal health coverage. Priority 4, NCDs. When you see these numbers, these figures, in 1990, 537 million years lived with disability, and more than 750 in 2010. So the key is prevention, but we know that it is a multi-sectoral approach, not only health. So socioeconomic, environmental, and behavior factors. My first decisions. First, speed up the implementation of the Framework Convention on Tobacco Control. We have to be fast for that. Second, we have to harmonize norms to reduce sugar, salt, and unhealthy fat content in food. It is not done. We have different norms in the world for that. And strengthen the role of WHO in health education programs. 5, strengthen the primary healthcare systems. If I have to define the first duty of the next Director General of the WHO, I would say strengthen the primary healthcare systems. To implement a universal health coverage, to have equitable and responsive health systems. It is a key. When I see sometimes some heads of state, particularly in Africa, asking a big hospital with a university, when I ask the fund we have to do that, With this money, we can treat, thousands and thousands of children with diarrhea and pneumonia. We could buy thousands of gene experts diagnosis. We could have a lot of point of care in all the country. So public health is probably the key to ensure vulnerable groups are prioritized. So first, talking directly to the heads of state and show them the impact of health investments on economic growth of their countries. I don't think that the next DG of the WHO has to be too technical. I think that he has also to be political and to speak directly to heads of state, because public health is a political issue and not only a technical issue. We have to speak to heads of state to say that health is not only a cost, it is an investment for the GDP. So we have to consider that for the choice of this position. We have also to speak about better financing with member states, international funding agencies, and private sector. Implementation of a Department of Innovative Financing for Development. Stefan said that at the beginning. We have to understand what happens today in the world. The populisms are increasing. The nationalisms are increasing. The selfishness of the OECD countries are increasing, are growing. And we can see in France, for example, in my country, I can see that the extreme right-wing party is growing. And the discussion at the parliament are not very good for the official development aid. This year, we can see that in 12 or 13 countries, the parliaments decided to decrease the ODA. So it could be very difficult to continue to stabilize and to increase the ODA. We have to do that. We have to push governments for that. But it could be very difficult. It is a reason why we have to create new sources of finance. In 2006, I created UNITAID. It is a small idea, UNITAID. A microscopic solidarity levy on per plane ticket, €1 or $1. It is a big failure and a big success. It is a big failure because only 12 countries accepted to implement this mechanism, 12 out of 194. But it is a big success because with these 12 countries, we raised between $2.5 and $3 billion. And this money is sustainable, predictable, and should be additional. With this money, we decided to work on the market dynamics, to decrease the prices of drugs, medicines, and test diagnosis. We obtain a reduction by 80% for the drugs, the antiretroviral against HIV for children, 60% for the second line, 60% for artemisinin, and 40% for tuberculosis test. We implemented gene experts. So we proved that innovative financing could be useful. After that, we divided innovative financing in two parts. Innovative funding, $1 per plane ticket, or 10 cents per barrel of oil. but also innovative spending. What is innovative spending? One example is given by the medicines patent pool. You know, when you have a breakthrough at the laboratory in research, 10 years after you have the drug, the more recent, the more expensive, and the more efficient drug. It's good for us. But in Addis Abeba or in Bamako, you have to wait between 15 to 20 years to have this drug. For HIV, we asked the main pharmaceutical industry companies to say, look, you are going to keep your intellectual property. You are going to keep your patents. But is it possible for us, Unitaid, to organize some licensing with genericals for low and middle income countries? At the beginning, it was a big fight. After that, with Pfizer, with Glaxo, with Roche, with Merck, now we have the first medicines patent pool of the history of the humanity, and the most efficient, the most recent drugs are at the same time in Washington and in Bamako. So I think it's for 98% less expensive. So I think that we can work on that. We have to innovate, because if we don't innovate at the WHO level, it will be very difficult to continue to want to achieve the Sustainable Development Goal 3. We have also to convene a global interagency task force for migrant health. We see that in Europe now with, in Turkey, in Greece, in Italy, we have a lot of refugees. In Jordan, we have a lot of refugees, and we cannot let these refugees without vaccine, for example. 6, availability, accessibility, and affordability of essential medicines. I spoke about a medicines patent pool, but you know that 1/3 of world's population doesn't have access to essential medicines. So when you see for diabetes at the top, when you see for pregnant women with anemia, when you see pneumonia, antibiotics, or only 1/3 of acute diarrhea cases receive medication, when you see that, I think it's impossible to achieve the universal health coverage with this kind of figures. So my first decision could be to ensure that missing essential medicines that lacks a profitable market are nevertheless developed and provided to the poorest. Medicines patent pool is one of the answer, but not the only one, and develop public-private partnerships. And the last one is antimicrobial resistance. Antimicrobial resistance is now occurring in all parts of the world. And without action, many of the important gains we have made during the last 2 decades will be at risk. So first, we have to implement the plan presented by Lord O'Neill recently during the last General Assembly of the United Nations. We have to reduce demand by restrictions on cross-border and on online sales of medicines. We have also to communicate and educate to reduce demand and overprescribing, and also One Health with the problem of agriculture. and of course, increase the supply of new drugs to overcoming AMR. Everybody knows that there is an underinvestment by pharmaceutical companies during the last 2 decades. It was my small remarks to begin and to open the discussion. Thank you very much.
Thank you. Please. Let's just... Well, thank you very much. You've given us quite a bit to think about. Let me begin by asking you, you made a very clear case around trying to prioritize, and this is prioritizing has been the bane of all director generals of WHO. It's just been difficult. You're pulled in so many directions. So saying that you're going to stop doing certain things carries a price with them, with some constituency or another. Your argument across the spectrum of things that you're talking about doing, you're arguing for much enhanced leadership of the Director General, which is refreshing. And you're saying you're going to, you see this role as a statesperson's role, and you see this one as setting agendas and speaking truth to power and driving processes forward on multiple levels. And I commend you for that. I think that vision is an exciting one. It's a provocative one. But tell us, what do you think WHO needs to stop doing that it's doing today?
To do everything. First, we cannot do everything, and we have probably to stop to non-evaluate. You know, I want to begin with the first slide. You know, about the audit function. We need to have a strategy. We need to discuss with member states, but we have to give them a vision. Because you cannot say to all the member states, I am going to do what you want. Because at the end of the day, it's impossible to say yes to all the board members. So probably we have to convince member states, and not only ministers of health, but also heads of state, to share this strategy. And probably not to, I am in campaign, so I have to be careful, but not to say yes to all the countries.
What you're proposing, the battery of changes that you're proposing are ones that many of them are long overdue, many of them are new opportunities that are appearing, and you've made a very important point that these require support from political leaders, from state leadership. It's beyond simply talking to other health ministers. You really need a strong nucleus of high-level, empowered and focused allies with you. Who do you think that nucleus would be? If you step into power July 1st and you're trying to move this agenda, and you need 4 or 5 heads of state as your nucleus of to make sure that you can carry this agenda forward, because you can't do this alone.
Exactly.
You have to have that nucleus of powerful heads of state behind you. Who would that be? Who would that be? Because otherwise you're stuck. You're
of course.
You're toast.
No, take the example of antimicrobial microbial resistance. A lot of people spoke about AMR for a long time. One day, a minister of budget from the UK, Lord O'Neill, the best friend or good friend of the Prime Minister, said, it's absolutely awful, It is a big challenge, but we are not going to stay between ministers of health with that. We are going to go to the G7, the G20, and the General Assembly. It was Lord O'Neill. And Lord O'Neill, made a report, and all the head of state of the G20 spoke about the antimicrobial resistance. And the General Assembly was, aware of this problem. So it is the example of if you don't go at a high level, political high level, it is impossible to move forward.
Mm-hmm.
But about the nuclears, we can have, why not the next president of the US? It could be a good partner for that. Global health is probably, international sanitarian security is probably one of the most important things during this century. But when we founded UNITAID, for example, we had Chile. Chile is a good example with one head of state who is a medical doctor,
right,
who knows very well the global health, who chaired UN Women, and it is the example of a person who we can begin to have reasoning.
So you think that in order to get the attention, you're using the AMR example, in order to get the attention of a core of powerful heads of state, you're going to need to be able to make a very strong security case, that your agenda is important to global security, that it's very important to economic future growth and prosperity. You would see yourself grounding most of your arguments as you went around trying to connect to busy heads of state. You would be making that case as a lead case on top of the obvious humanitarian and ethical considerations that drive much of the work.
Yes, during the last conference for development in Addis Ababa in July 2015, one of the main conclusions were the necessity to increase the domestic budget for health. So we have to continue to help with ODA, but we have also to ask head of state to give more for health and for education of girls, for example. So this kind of thing is absolutely political. It is not only technical. It is so we have probably to have a department, or we have to work with World Bank, IMF, some member states, to have a small team to speak about this necessity. Because all the countries are interconnected. So what happens in Mali is interesting for the US and vice versa.
Right. I do agree that we're likely facing flat or declining budgets in terms of ODA, right? I mean, this is what we were talking about in Durban, and the trend lines are fairly clear. How you motivate low income and lower middle income countries to make those investments in health is going to be a big challenge. The predictions that were made that as they advanced in their growth over multiple years, that they would see corresponding increases in health budgets haven't been realized in most cases. So how would you see your role in prodding? I understand what you're saying. I want to get in a moment to the innovative finance piece, because that comes out as such a prominent piece of your argument. But I wanted to ask you, how would you be using your bully pulpit in order to get states themselves low-income and middle-income states to invest at a higher level in health?
First, we have to say that there is a debate because some high-income countries say that we have to help a lot of low-income countries, but for the middle income, we are going to say to them, you know, you are more rich now and you can pay your structures. It's true for all except for health, for me. It's a big debate between some countries because 70% of the poor people in the world are in middle income countries. So I think that we have to probably to push these countries to increase their budget, of course, but also we have to understand that it is very complicated for them also. The second thing is about, more concretely for the WHO, the international health regulations. If you want to have international health security, we need to ask each country to respect the international health regulation. It's impossible to do differently. So we have two possibilities. We can say, okay, you are going to evaluate yourself. I am in campaign, I could say that. It is a big mistake. We have to evaluate each country. Are you able to respect your international health regulations? So I discussed a lot yesterday and the day before yesterday with a lot of ministers of health from South America about that. They told me that they have an evaluation agency in each country, and probably the role of the WHO could be to make an agreement with, or not, with the evaluation agency of each country. So for example, in Paraguay, if we see that the agency for evaluation is good, we can believe them. If we see that it is not good, we have to transparently make an evaluation ourselves.
Right. You know,
it is a key for.
Yeah, I was happy to see your call for independent assessment. There has been progress between the U.S., the Global Health Security Agenda, and WHO in putting together a common tool, the joint assessment tool for looking at the competencies, the capacities in different countries in meeting their international health regulation obligations, and that's quite promising. It's at an early stage, but it's generating more and more cases of this, and I would hope that would continue. It is a bit of an uncertainty here in the United States as to whether the next administration will be able to go to Congress and re-up those commitments, because much of the money that's come in was emergency funding under Ebola supplemental funding, and that's going to run out in time. Let's talk a little bit about innovative financing. I mean, you have been a pioneer in that area. You've had success. You're carrying that spirit and that logic into this vision for WHO. You're proposing that perhaps a micro levy could be used to pull WHO out of its budgetary traps. Right now it's 80% targeted, dedicated funding, and only 20% that is for core operational requirements. And as long as WHO stays in that trap, whoever's the Director General has very limited sway, right? Very limited authority. Plus you have to share those funds with the 6 regional entities. So at the end of the day, what are you left in your pocket in terms of your ability to move events and shape things? So getting some balance back into the budgetary picture, getting more control and leveraging authority will be very important in making sure the next Director General is able to have much more influence and sway. So you're suggesting that innovative financing might be one way to do that while also shaping market prices, which you made that argument, I think, very, very cleverly and very effectively. What are you going to tax?
Pardon me?
What do you want to tax?
No, no, no. I am not going to use this word in the US. And during the presidential election.
We occasionally use that word here.
No, I know that I am French, but we like tax. No, I think that...
We can call it a micro levy. It sounds, sounds better here.
No, no, no. When you see innovative financing, only 4 or 5% of innovative financing are coming from levies, in fact. And during the last 6 years, it was about between $7 to $8 billion of innovative financing, and only 3, 4, 5 from levies. Now, I think that we have to develop probably a lot of private-public partnerships in the financial field. We can develop some social investments with a lot of banks, and we begin to have some discussions with a lot of social invest funds. I clearly believe that it's possible to do that tomorrow. It's not only levies and tax, except the fact that in France we implemented a financial transaction tax, 0.001. Nobody is going to be poorer, 0.001 per transaction. If all the countries do that, it could be 400 billion a year. But it's a dream. It is not in the role of the DG of the WHO to do that. But, you know, I do think that we live with the globalization of the economy, with the globalization of the communication. We don't live with the globalization of the solidarity. So we have probably to create this kind of things. I don't know how, but finally, I would like to tell you one thing about financing. When you see the excellent job of Jim, you know, the IMF in one end, but essentially the World Bank. It's absolutely unbelievable to see the sum of money of World Bank for health. I do think that the WHO has to be the leader. But we have to work with them more closely. We have probably to work on this agenda. Which priorities? How we are going to work together to achieve these priorities? Probably more than now. Probably.
So you would see yourself as playing a stronger leadership and convening role with all of the other important agencies that are out there. In other words, you would see yourself in a much closer dialogue with the head of Gavi, with the head of the Global Fund, with the World Bank, with...
Yes.
I mean, this is a very fragmented architecture, and it's one which, as it's evolved over the last 15 years in particular, has made WHO implicitly more marginal in a way. So you're trying to recapture ground on the leadership side through diplomacy.
You know, when you see Global Fund and Gavi, it is probably the more successful stories of the humanity for health. So, and Mark Dybul, for example, is absolutely an unbelievable guy. you know, it's a magnificent job. But if you have taken 15% from the beginning, 50% of the money of the Global Fund to strengthen the primary healthcare systems in the world, probably it could be better. So now the Global Fund does that. But I think that the vertical fund is a very good thing, but probably we have to work with the vertical fund, and the vertical fund has to work with the WHO to have a transversal vision.
Yes. I mean, we just had the...
It is not to recapture, it is to work together.
Yes, yes. Let's talk for a moment about pricing and affordable access, since that is one of the most sensitive and one of the most complicated issues. It's risen in importance and visibility. We just had the completion of a high-level panel on access to medicines. Your government has been fairly vocal on the whole question of pricing and affordable access. How do you see your role as the Director General of WHO in driving towards progress in that area, particularly given that WHO historically has had such trouble engaging private sector? It's had very difficult relations that have set it apart as an institution from other UN agencies and other international bodies. And there are reasons for that, but it is a very difficult, strained set of relations, and yet it's terribly important to get to the next phase that there be leadership addressing these very complicated issues which have become so polarizing. I mean, during the high-level panel when it was underway this summer, there was enormous anxiety within industry around whether this would have result in lasting damage to intellectual property rights. The conclusions of that report were not revolutionary, I didn't think. I mean, they were calling for certain steps to happen, a high-level panel, many by the Secretary General, many by WTO, some by WHO, but less. Could you just say a bit about how would you fit in that big agenda on pricing and affordable access?
No, first, we have to consider, the private sector is not by definition an enemy, because if you don't speak with the private sector, you cannot have a private-public partnership. So the medicines patent pool is an example of a private-public partnership. So in my first remark. The second one is about the neglected diseases, for example. When I founded UNITAID, we didn't have any antiretroviral for children. Why? Because all the pregnant women with HIV in rich countries was treated with antiretroviral, and the newborn were not infected. So if you are the CEO of a big pharmaceutical company, you don't have to develop any drugs because you don't have a market. But you forget at the same time that more than 1,000 babies were born each day with HIV. So when you don't have a market like that, I think that the role of the WHO is to develop this kind of drugs and medicines, because the rules of the market are not sufficient to do that. So I do think that we have to speak about neglected disease. When the market is not there, we have to work with private sector. And we did that at UNITAID with CIPLA, for example. And we have a tender, and CIPLA won the tender. And now, between 2007 and 2011, 8 out of 10 children who were treated against HIV were treated thanks to Unitaid. Mm-hmm. My second remark is about, it's impossible, you know, I am not going to say that we are going to reduce the price, but PAHO made a very good experience with some countries which were too small to negotiate price for example, hepatitis C treatments. So PAHO took a lot of countries together in the region to say, okay, look, we are going to go together to negotiate the price. Mm-hmm. And it works. So to answer your question, I think the role of the WHO could be also that. When you are in an island with, 200,000 people, it's very difficult to go to see Gilead alone. But if you come with 30 million people, it's easier.
On the question of research and development, there were some very interesting ideas in that high-level panel report, and there were many in the Ebola analyses, the post-Ebola analyses. There seemed to be a proliferation of ideas, some of which are now getting developed. You know, you had the CEPI initiative that grew out of Davos, and that is, under development now, bringing together foundations, governments, industry in an interesting way. It just seems to me that the R&D agenda, trying to get those key constituencies aligned in some new way to bring forward significant enough resources to create platforms for developing the vaccines and therapies for these neglected or sub-market diseases, that there's a lot of promise right now, that this is an area
Absolutely.
Where the politics is not so poisoned, and in fact it's working in the opposite direction, and in which there are already significant resources. Just look at the U.S. side of things. I mean, the dollars that continue to be moving. And I wanted to ask you, do you see things in that way? Because you think in these terms, and you have for a long time. And it's just my impression from reading these reports that there continues to be an optimism and a creativity around these ideas around R&D, and that if you were to be the Director General, that you would bring that knowledge and expertise into this position at a particularly favorable moment.
Absolutely. I think that we have in a turn point. Everybody understood that we have to go there with the NID, with a lot of groups and teams now. We begin to have more help, and we don't have a fight between the big pharmaceutical companies and this kind of stories. So I agree. Medicines patent pool is probably the first one, but now we are going to begin with tuberculosis. Mm-hmm. As you know, we have 2 new antibiotics against particularly MDR-TB. So it's absolutely crucial. We were waiting for that for a long time. And we have to continue for hepatitis C now.
Thank you.
But for cancer is probably the key. Because my problem is to see that in the life expectancy in Africa is growing, and the number of cancer is growing. So I am afraid to see that the treatment against cancer is very expensive. Mm-hmm. And the more the time spent, the more you have individualized medicine with a high price. So I don't know how we are going to manage that. We have the prevention, but also the individualized medicine. So we have probably to move forward very quickly to allow all the African and the poorer countries in the world to have access to treatments against cancer.
Thank you. A couple of specific questions, and then I want to open to the floor. You mentioned as one of your priorities to accelerate speed up the implementation of the Framework Convention on Tobacco Control, which of course is an exceptional convention, in terms of a legal instrument that WHO has. It's an exceptional and a unique power and instrument, but it's stalled in the last several years. Progress has stalled. How would you, I'm very encouraged to hear you identify that as a priority. How would you do that? What would it take? Again, it gets back to a nucleus of state powers.
Exactly.
Because state powers have the capacity. Much of this is a matter of regulatory environment, right? Mm. So tell me, where would you look? What would be the
No, we have some leaders in the world for that. We have the president of Uruguay, for example. Mm-hmm. It's amazing. It is a professor of cancerology who increased the taxations by, 20, 30, 40%, and was re-elected. So you can be re-elected with tax, And we have also to work on plain packaging. In my country, in the UK also, we implemented the plain packaging. For the Tobacco Convention, we have to take 5, 6 heads of state and to have a small team to make some advocacy for the colleagues.
And would you see yourself partnering closely with Michael Bloomberg?
Yes, of course. Absolutely.
Yeah. I mean, there's a very strong interest certainly there in this. And I think people would welcome seeing a revitalized, a re-energized effort in that area. Two other things. I mean, you made mention of the migrant population, which of course is at epic levels, unprecedented levels today, and there's no indication that the 65 million displaced and refugees is going to abate anytime soon. And those populations are emerging out of countries that are broken, dissolved, and often at war or very fragile states. So the migrant piece is blended in with fragile or broken states. WHO has been called upon to play some roles in some of these dire, violent settings, but it's really been a bit beyond their capacity to do. I mean, it's the responsibility to address the dire health requirements tends to migrate somewhere else. Tell me how you would see WHO expanding its engagement in these areas, there is clearly an enormous shortfall of capacity and response, and it is going to be, I'm certain, in the 5-year tenure and the 10-year tenure of the next director generals in WHO, this is going to be a pressing demand. It's not going to abate, but WHO is not built to be very effective in this. So how would you? You couldn't bite off too much, but I think being more engaged will be very needed and very welcome. It's just the question is to do what?
In August 2015, I went alone, without photographer, without camera, alone, on the boats with HCR between the Libyan coasts and Lampedusa. Yeah. And what I saw is absolutely unbelievable. So the burns, for example, You can see in Lampedusa, in, I don't know, 10, 12, 20 women who arrived with big burns with oil, salt, and sun. At the 3rd degree, it's very, very serious. Some are dying like that, without nobody, because the baby were under them during the travel, the trip. The vaccinations, we need to vaccinate children. And Italian people do that. Greek people do that in Greece. In Turkey, the same. In Jordan, the same. But it is impossible to ask these countries to do that alone. So we have probably to have a big thinkings at the WHO and at the UN in general about the health of these migrants, and particularly for children. If you consider the vaccinations, for example, it's absolutely impossible in the WHO to ignore that. Mm-hmm. It's a big, big, big threat. In Jordan, for example, it's very difficult for the country to continue to do that alone. So, yes, we have to say that also.
So you would see, either through Geneva or through the Cairo office or in the other regional offices, you would see them investing at a higher level in order to be of assistance in these emergency requirements.
Absolutely. I would like to make two more remarks about two things, because I didn't speak about. The first is the violences against women. Mm-hmm. Because when you see the figures, it is a big, huge public health problem. And we have to speak with UN women more than now about these terrible things. And also mental health. In more than 100 countries in the world, the patients go to jail or something like that. So we cannot probably, we have probably to, it is the role of the WHO to speak about. It is not, but we have to be the advocates of the dignity of these patients, because today these patients are not recognized as patients. And I think it's the worst thing in the world.
Thank you. Why don't we open to our audience, and what we'll do is
My God.
we will take very brief interventions from 3 or 4 people at a time and come back to you, and we'll do a couple of rounds of this. So why don't we just start here, Larry? Yes, Diadji? Yes? Yeah, why don't you start and then...
Sure. I have to say, such a thoughtful conversation between the two of you, much better than our presidential debates. Much, much better. Philippe, I was encouraged, as Steve was, about your kind of normative and moral claims that you're making in 3 of the areas, but I could think, but every area, but 3 of those areas, tobacco, the international health regulations and global health security, and refugees, all have international treaties behind them. And I think there are ways to kind of push those treaties forward. I would like to hear you say a little bit more about them, but maybe rather than the 3, I'll just focus on the international health regulations, because it occurred to me that if you were elected, the world would have come around in a circle, because you may or may not know that The very first International Sanitary Conference that led to the IHR was in Paris in 1850. So what would you do in terms of leveraging finance? So for example, if countries didn't form their health capacities as required, could WHO, say, in partnership with the World Bank's pandemic facility or the Global Health Security Agenda, to actually condition funding based upon that, based upon their compliance? And then secondly, when we saw Ebola, H1N1, you name it, countries slapped on travel and trade restrictions against strong WHO advice. How could we enhance that compliance?
Hold for 1 second. Can we take a couple of other interventions? Yes, right here, please. Please identify yourself and then go, please. Yes.
Hi, Tiaji Salam Blyther, Congressional Research Service. I'd like to hear a little bit more about your thoughts regarding the tensions between decentralization and accountability. On the one hand, decentralization does bring more autonomy to the regions, but at the same time, with implementation and hiring decisions being in the field, that puts the onus on WHO Geneva, which may not have any influence on how that happens. And we saw that happen with Ebola. Some of the political issues that happened within a region fell back on WHO Geneva, which did not have the authority to do much about it. So I want to hear more about how you tend to strike this balance. Thanks.
Tiaji, right behind you, please. And then we'll come back to you, Philippe. Yes, please.
Hi, Zach Struver from Knowledge Ecology International. There have been discussions and proposals over the years to end patent monopolies and high prices and the associated rationing. And I was wondering, as WHO Director General, how you would advance discussions and proposals that would progressively implement the delinkage of drug prices from the costs of research and development. Thank you.
Why don't we
What is the last one?
This question is about how would you use your good office to advance a delinkage between patents and prices? Is that correct? Drug prices and is that? Yes.
Okay. Now, about international health regulations, I think it's a key. And when you are DG of the WHO and when you go in a country, when you know that the IHR is not respected, I think that you have to say that, and you have to say transparently that, and you have to say publicly, and to ask the head of state to increase the budget for health. I think it is one key. I was a politician, so I know exactly how the brain of a politician works. So you have to do that. And because it's very good to have the ODA, but it is better to have also the domestic resources. So I think the international health regulations is a key for that. And the second one, it was? Okay, thank you. About decentralization and assessment, it is a big question. It's impossible. I was mayor of Lourdes and Toulouse, in the southwest of France. We build Airbus. I don't know if I have to say that, but we build Airbus in Toulouse. So Toulouse is a town of 500,000 people. When you are mayor, you need to know everything on the ground, because people want that you know everything. The light, the roads, etc. The bus. So I am in favor of the decentralization, because you can know everything at the top level. It's impossible. But you have to do two things at the same time. You have to decentralize, but you have also to evaluate what people do on the ground. Because if you don't link to result, if you continue to decentralize like that, it's a bad thing also. So it is my answer. You have to do both. It's absolutely crucial. But it's impossible to say that in Geneva we are going to decide everything for all the countries. It's a mistake. But we have to have a good staff on the ground. The third is about patents and prices.
Mm-hmm. R&D costs and patents and prices, yes. Which gets us back to the central issues debated out in the high-level panel.
Yeah. I think that the WHO, the DG of the WHO must have only one ID, accessibility, availability, and affordability. It is the role of the DG of the WHO. After that, which is power for that? You have pharmaceutical companies. We can continue to have a big fight between some and some, but at the end of the day, everybody lost. So we have to build private-public partnerships. When I began this licensing of patents with genericers, everybody was against me. On the board of Unitaid, we were only 3. After 4, after 5, after as a unanimity, except one, abstention. And now, when I see Pfizer, and when I see the CEO of Glaxo in the FT 3 months ago, saying, I am proud to have done medicines patent pool for HIV, I propose to do the same thing for cancer, I am happy. Because we have to work with private sector.
I just want to say that Sir Andrew Whitty made that very statement here at CSIS on March 17th in a very dramatic way. We have a hand right here, and then Jean-Luc, I hope we can hear from you too. We have the,
Yes, thank you so much for your remarks. Michelle Brooks, I'm with Uniting to Combat Neglected Tropical Diseases Support Center. Tomorrow, USAID will be celebrating its 10th anniversary of the Neglected Tropical Disease Program. There's been tremendous progress in the fight against NTDs. They were added last year to the global goals, so now they're sitting alongside HIV, TB, malaria. We had 31 countries sign the Addis Ababa commitment to NTDs. So we'd like to know, if you become the next DG, what you would do to continue the progress against the fight for NTDs.
Thank you. Michelle, could you hand it to Gianluca behind you, and then we'll go to Carolyn. Yes.
Thank you. Gianluca Burci, adjunct professor of international law at the Graduate Institute of International Studies in Geneva, but also former legal counsel of WHO for many years, and I had the opportunity to meet Mr. Douste-Blazy when you were chair of the Unitaid board. Very thought-provoking discussion. I would have many questions, but I would like to focus on one. If you look at the antimicrobial resistance declaration, at the high-level panel report, at so many other statements, they focus on what they call the policy incoherence at a global level, that there's no coherence between economic considerations, trade, environment, agriculture, nutrition. There ought to be a bit of a silos approach, both at the national level and the international level. And it seems to me that health sometimes is a victim of this incoherence. It's not the strongest advocate, it's not the strongest constituency, and it suffers. If you agree with this assessment, what do you think should be the role of WHO to get a better balance sheet for health? Because at some point, for example, with Director General Brundtland, WHO was much more politically active. For example, the Doha Declaration, in good part, came from the personal involvement of Dr. Brundtland. Or WHO can be a good technical agency, provide technical support, doing follow-up, like we are doing in the case of the NCD declaration. But these are very different visions of WHO. How do you see WHO in this broader context?
Jean-Luc, could you hand just a row behind you there? Carolyn?
Hi, thanks. Well, Carolyn Reynolds from PAF. Great to hear you talk about the DG needing to speak truth to power, because that's what we all hope to see. Very important. You laid out a lot of strategic priorities. One you did not talk about was women and girls and families. You talked about violence against women a little bit towards the end, but how does that factor across your strategic set of priorities, which obviously touches on all the things that you talked about? And also just to, you said priority 5 was investing in strong primary health care systems, which we obviously strongly support, but you actually said that would be priority 1, but it was priority 5. So just in terms of where does that fit as well? Thanks.
Girls.
Family, girl,
Yeah.
yes. Women, girls, families. So we have an NTDs question, a policy incoherence question, and women.
No, we are about NCDs. We are going to continue, of course. And, in 2030, we are going to have more NCD than infectious disease. So, of course, we have to work together and to continue to develop this collaboration. NCDs is probably the most important thing. It's a problem of diabetes and overweight. And
I think Michelle was referring to the neglected tropical diseases.
excuse me.
Yes.
J'ai pas compris. About what?
In neglected tropical diseases.
Okay. Could you repeat your question, please?
Certainly. Neglected tropical diseases have made tremendous progress,
yes.
and
Okay.
so we'd like to see what the new DG would do about continuing that progress.
Yeah. About, neglected tropical disease, it is a problem of neglected disease, not only tropical. And when you discussed with Pasteur Institute, and when you discussed about, for example, some disease, they said that it was possible to have a vaccine, or it was possible to have the treatments 40 years ago. But nobody was interested in that because it wasn't possible to earn money with that. So we are exactly in the center of the problem of global health. Is it possible to continue to have the same system, the market? Is it possible to continue to consider that health products should continue to be considered as a simple market? My answer is yes for a lot of disease, but my answer is not for example, tropical disease. It is a big challenge, but the role of the WHO is to work with research centers to have vaccine, to work on treatments more than now. In Pasteur Institute, it's exactly the example. They can tell you that we are going to have a lot of threats in the future, and nobody is interested in, because you don't have money to earn. So I think that we have probably to, I don't know what we have to do as Director General of the WHO, but we have probably to, I don't know if it is advanced market commitment system. I know if it is, but we have to innovate to be faster in the research and treatment for neglected tropical disease, because it could be a big threat for the world. About the incoherence between trade, agriculture, etc. So, first of all, about antimicrobial resistance, I will tell that we have to work about one concept, one health. Agriculture, animal, vegetal, and human. But the role of the WHO, to answer your question, is to be political. And I agree with you, Brundtland was political. And she was a very good DG for me. She made one term. We need to be an advocate when you are DG of the WHO. We have to be an advocate of public health and global health. It's very unpopular sometimes. I agree with you, because we have a lot of incoherence, but it's not a problem. You have to be courageous. And thank you for this question. We have to be proactive in this political aspect. About family and girls, I apologize if you think that I don't speak about that. Yes, I spoke about that. When I say that I want to strengthen the primary healthcare systems, it is also for family and girls, because maternities, it is for me the primary healthcare systems. Midwives, it is the primary healthcare systems. Point of care for HIV, for tuberculosis, for malaria, for fever, it is a healthcare system, primary healthcare systems. So I agree. During the last 2 decades, the maternal mortality and the childhood mortality has been divided by 2. And we have to continue to do that, of course. Of course. But I cannot take a list of, because I don't want to do that. It is my strategy. My strategy is to strengthen the primary healthcare systems. And, pregnant women are the first interested in the primary healthcare systems.
Are you comfortable going a few minutes over?
Yes, the last question, because I have to leave Washington, unfortunately, to go to Paris.
Right here, please. You win the prize.
Kate Telenko with InterHealth International. You mentioned the need for human resources reform, which I think everyone in this room is delighted to hear. There have been a lot of different proposals. What's new and different about what you're proposing, and how will you implement it?
During the last General Assembly last week in New York, France and South Africa co-chaired a commission on human resources. It is probably the main problem to strengthen the primary healthcare systems. The problem is that with the tax and the budget of a country, a lot of people become medical doctors, nurses, midwives, and after that go to Western countries. How can we keep these people? One thing for me, one solution for me, is to ask these people to stay for 2, 3, or 4 years as an agreement with the state. To say it is your duty to stay there. I discussed a lot in PAHO with these issues, with particularly the Minister of Paraguay. And I told him that in France, even in France, we have a problem with the medical doctors in landscape, in countryside. And I told him that for me, it was probably necessary to ask this small medical, this young medical doctor to be in the countryside for 2 or 3 or 4 years. And he told me, I did that in Paraguay, and I obliged my young medical doctors to go for 2 years in countryside, and they married. So they stayed there. It's perhaps one possibility.
Well, you've given us an enormous amount to think about, and thank you. And
I can tell you one thing.
yes.
I was destabilized because you have the face of one of my competitor there from the beginning. Don't show, please.
Well, it wasn't my intent, but I think we had a great conversation, so maybe it's a helpful tool. But thank you so much, Philippe, for coming and being with us, and for being so candid, and also for coming with such a rich agenda, such a rich vision. You've given this obviously much thought, and you're thinking way beyond where we are today, and I think that's very refreshing. And so we appreciate this. I think we all benefit from having these sorts of discussions, and I wish you the best in your campaign.
Thank you very much.